topic is at which number? Surgical induced scleral necrosis. Once in blue moon. It's your topic. You can present your topic. You've got 3 minutes for the presentation.
Good morning, sir, and my fellow colleagues. I'm going to present a poster on the topic surgically induced scleral necrosis once in a blue moon. My patient, can I skip this? My patient is a 71-year-old male who presented to our OPD with a complaint of diminution of vision in his right eye for 6 months, excessive tearing, discomfort, redness in his right eye for 2 months. He had history of hypertension for 20 years and type 2 diabetes mellitus for 15 years. 2 months back, he was operated for RD. The surgery done was vitrectomy with scleral buckling with ERM peeling. The diffuse torchlight examination of my patient was normal. His ocular examination, the best corrected visual acuity in the right eye, that is the concerned eye, is 1/60. In left eye, it was plain 6/12. Rest everything is normal. The slit lamp examination of the right eye, in the conjunctiva, the conjunctiva is retracted and congested, and scleral thinning was observed with exposure of the underlying uvea and prominent episcleral vessels. Rest normal. The left eye slit lamp examination is normal. The fundus examination of the right eye, the fundus of the right eye, the disc was vertically oval and tilted, size was normal, color was pale, margins were intact, the CDR was quite raised, that was 0.6. In the background, I observed AV nipping present in the inferotemporal quadrant. In the inferotemporal quadrant, which is a sign of hypertension. The blood vessel, there was nasal shifting, rest normal. The fundus examination of the left eye, in the background, in the superonasal quadrant, the soft exudates were observed. In the blood vessel, copper wiring and vascular shedding was present in inferotemporal quadrant. The relevant investigations, ANA was done, that was negative. RA factor was done, that was negative. The provisional diagnosis of my patient is post-retinal surgery-induced scleral necrosis. The management that we advise for eye drop CMC with 10% vitamin C, eye drop moxifloxacin, eye drop prednisolone, tablet doxycycline, tablet Visolone. The surgical intervention that we advise was scleral patch grafting and buccal readjustment. In this case, excessive tension due to scleral buckling might have led to the scleral ischemia. Advanced age and comorbidities like diabetes and autoimmune diseases can impair wound healing. So there was diabetes in our patient. Minimizing cryotherapy and careful placement of scleral buckling can reduce the risk of ischemia and necrosis. Early signs of scleral necrosis should be promptly identified and intervention should be started as early as possible. Timely surgical management, including scleral grafting and possible buccal adjustment, is critical to preserve ocular integrity and visual function. Prevention through careful surgical technique and minimizing trauma to the sclera is key to reduce the incidence of this complication. Thank you.
Very nice presentation, Dr. Reena.
Thank you, sir.
The thing is, the patient was operated for RD surgery, that buckling was done for the...
Yes, sir.
And what was the post-op result of this patient after the surgery, after patch graft?
Sir, actually, the patient did not have the pre-op findings, that pre-op visual acuity. So the patient came to us after the operation. The operation was done outside in a private setup. Right. So when the patient came, his visual acuity was 1/60. So we don't know what was the pre-op.
No, post-op. What was the post-op result of this patient after the scleral patch graft?
So actually the patient was lost to follow.
Okay. So the patient didn't get the treatment.
No, sir.
It was only just to suggest this treatment is possible in such cases. Yes. Thank you.
Thank you, sir.
What about the next presenter? Or next, what's your name? Do you want to present right now? Dr. Tejal Srivastava. What's your topic? At which number? Topic कौन सा number? Topic कौन से number पर रहेगा? तेजल का? अच्छा आपके पास लिस्ट है, ओके.
Good afternoon, sir. I'll be presenting my e-poster on anti-glaucoma drugs in herpes keratitis, adding fuel to fire.
Just wait. Yes. 692.
A 63-year-old male patient hailing from Azamgarh, UP, came with redness of right eye, along with the diminution of vision and discharge and foreign body sensation, which was insidious in onset since 4 weeks. He is a known case of glaucoma since 37 years who underwent trabeculectomy of right eye 38 years ago and left eye 25 years ago. He underwent right eye cataract surgery along with sectorial iridectomy 12 years back. In Feb 2023, he presented with redness of right eye, for which he was given ointment aciclovir in right eye for 5 days, for 5 times a day, which was stopped in May 2022. He was started on eye drop brinzolamide in both eyes twice a day from July 2022, presented with redness of eye again in 2024 Feb, and was started on eye drop travoprost, both eyes once a day, bromelain and timolol, both eyes twice a day, brinzolamide, both eyes thrice a day. Following which, after 1 week, his symptoms got aggravated. On examination, conjunctiva was congested in right eye. Pupil showed normal reaction in right eye along with peripheral iridectomy at 8 o'clock. Bleb was flat. And in left eye, there is normal reaction. Peripheral iridectomy was present at 1 o'clock. In right eye, central cornea showed mild corneal opacity along with peripheral vascularization, descemet membrane folds, subepithelial vesicles at 12 o'clock. And fluorescein stain was positive in right eye. Corneal sensations were absent in right and left eyes. And fundus showed pale disc in both eyes, and CDR was 0.5 in both eyes. His visual acuity in right eye was 1/16, left eye was 6/6 partial. CCT was not found in right eye, and left eye it was 500. Pupillary reaction could not be commented in right eye. On fluorescein staining, as we can see, there is a presence of central corneal ulcer, which shows dendritic pattern along with the terminal blebs. Diagnosis of necrotizing viral stromal keratitis was made, and he was given eye drop moxifloxacin and dexamethasone 6 times in right eye, CMC along with vitamin C, atropine, BD, and aciclovir eye ointment 3% 5 times a day. Left eye he was continued with anti-glaucoma drugs. As we know that travoprost is a prostaglandin analog, it causes side effects like ocular irritation, increased inflammation, iris changes, conjunctival hyperemia, and corneal edema. Timolol also causes conjunctival hyperemia, corneal anesthesia, and superficial punctate keratopathy. Bromelain causes conjunctival hyperemia and allergic blepharoconjunctivitis, and brinzolamide causes corneal decompensation in patients already having corneal endothelial dysfunction. Therefore, while using anti-glaucoma drugs in patients having herpetic keratitis, we should be using such drugs with caution. Such patients should be monitored and should be followed up for any symptoms, aggravating symptoms like redness. And therefore, if a patient with glaucoma is presenting with herpes, should be started on oral anti-glaucoma drugs if you have to control the IOP, and not on the topical drugs, as they are pro-inflammatory and cause aggravations of the symptoms. Thank you.
Very nice presentation, but one question I want to: if patient is allergic to these oral drugs, so what is the option do you have for?
Sir, we can use oral eye ointment like aciclovir.
No, for glaucoma medication. You're talking about anti-glaucoma medication.
Yes, sir.
But you're saying that every drug causes some or other side effect.
Yes, sir.
You're saying you should use the oral drugs.
Oral drugs.
So if the patient is allergic to oral drugs, what is the option left with you?
Sir.
So it's not that much. Basically, whenever there is an inflammation, the travoprost is to avoid it basically.
Yes.
Otherwise, you can use other drugs. That's not much unsafe in that using. It's not won't lead to the aggravation and inflammation.
Yes.
And the second thing, you should treat the pathology first, which is causing the glaucoma. That is because of this viral keratitis, which is causing the glaucoma. So if you treat the keratitis, the glaucoma will subside with the passage of time. And you can use topical drugs, not much, they are not much unsafe. Travoprost is to be contraindicated in case of whenever there is a keratouveitis is there. It will lead to more of the inflammation. Otherwise, other drugs are very much safe. Thank you. Next one is yours is.
Good afternoon, everyone. My topic is surgical management of acute hydrops in keratoconus at a tertiary care center of Jharkhand. Introduction. Keratoconus is a progressive bilateral corneal ectatic disorder. It manifests at puberty, late teens, and early 20s. It can occur secondary to trauma, vernal keratoconjunctivitis, congenital conditions such as Down syndrome, Marfan syndrome, and Ehlers-Danlos syndrome. Aim of the study is to see the effectiveness of intracameral injection of air and keratoplasty in different eyes presented with acute hydrops due to keratoconus. Materials and methods. 4 eyes of 4 patients of keratoconus presented with acute hydrops were included, 3 male, 1 female, with age range from 16 to 28 years. Intracameral injection of air was given in all 4 eyes. The period of persistence of corneal edema, the interval between the onset of acute hydrops and the time when the eye could begin to wear hard contact lens, and the best corrected visual acuity were observed to see the requirement of subsequent keratoplasty. This is the pre-op and post-op picture of the patient with intracameral air injection. Results. Full resolution of corneal edema was seen in 2 patients within 4 to 5 weeks. The best corrected visual acuity after the corneal edema subsided was similar for the 2 patients, which was 6/12, and both patients were able to wear contact lens after 5 to 6 weeks. In the other 2 patients, edema resolved into a scar, which was visually significant, thus penetrating keratoplasty was advised. Conclusion. The results suggest that intracameral air is safe and useful therapy to resolve corneal edema in acute hydrops secondary to keratoconus. Although intracameral air does not affect the final visual outcome, it reduces the duration of morbidity and also the risk of complications such as corneal neovascularization. However, in cases with extensive edema, when the hydrops heals and leave a residual scar, the patient may require keratoplasty for visual rehabilitation subsequently. Discussion. The cause of acute hydrops is rupture of Decimus membrane, which create a gap so that aqueous from the anterior chamber percolates into the corneal stroma. Intracameral air induces no complications. Other procedures such as compressive sutures along with gas injection, cyanoacrylate tissue adhesive with BCL, AMT, and cauterization has been tried in persistent hydrops. More studies with more sample size and long follow-up is required to know the long-term effect of the treatment. Thank you.
Very nice presentation. And
Thank you, sir.
the patient was there in the further in the follow-up for the keratoplasty.
Yes, sir. The patients were still in follow-up. The 2 patients.
Did you operate that for the keratoplasty or not?
Sir, they were advised for keratoplasty, but
due to non-availability of tissue, or it's your center is not managing keratoplasty?
sir,
Would it have been better to do the keratoplasty at the first when the patient presents with the acute hydrops?
yes, sir. The study is basically to see the effectiveness of intracameral air. So intracameral.
Thank you.
Sir.
Thanks.
Thank you, sir.
Our next speaker is
Ashna.
Dr. Ashna Uppal.
Yes, sir. So good morning, everyone. I'm here to present a case of herpes simplex keratitis with anterior uveitis. So introduction. Herpes simplex virus is a common cause of infectious keratitis and anterior uveitis. And herpes simplex keratitis is a recurrent disease that can lead to corneal scarring, vision loss, and increased intraocular pressure due to associated uveitis. This case report describes a patient with recurrent HSV keratitis complicated by anterior uveitis, highlighting the clinical presentation, diagnostic challenges, and therapeutic management. So the patient profile, a 35-year-old female, Pratima, presented to the ophthalmology clinic with a 5-day history of redness, pain, decreased vision in her right eye. She reported photophobia and tearing with a history of previous similar episodes, although less severe, occurring over the past 2 years. She had been diagnosed with herpes simplex keratitis in the past, but was not on any prophylactic antiviral therapy. There was no history of trauma, systemic disease, or any recent illness. So in the right eye, the best corrected visual acuity was 624. Slit lamp examination shows conjunctival injection, dendritic lesions on the cornea, central staining on fluorescein, and mild stromal edema. There was 1 plus flare, 2 plus cells in the anterior chamber, indicating anterior uveitis component. Intraocular pressure was elevated at 28 millimeters of mercury. Pupil was mildly sluggish, but there was no afferent pupillary defect. Fundus, the posterior segment examination was unremarkable. Left eye, the visual acuity was 6.6 and the anterior segment was normal. So this picture shows the dendritic lesion. The patient was diagnosed with recurrent herpes simplex keratitis with concurrent anterior uveitis and ocular hypertension. The corneal dendritic ulcer with associated uveitis and elevated IOP are the hallmarks of HSV keratouveitis. Immediate treatment was initiated to address the viral keratitis, inflammation, and elevated IOP. So topical antivirals, ganciclovir 0.15% gel 5 times daily for the dendritic keratitis. Oral antiviral therapy, valacyclovir 1000 mg 3 times a day for 10 days. Topical steroids, now they had to be started cautiously due to the epithelial defects. So after 4 to 5 days, the patient was started on prednisolone acetate 1% 4 times. For topical cycloplegic, cyclopentolate 1% twice daily. IOP lowering agent timolol 0.5% twice daily was used. Follow-up, at the 2-week follow-up, the patient showed significant improvement. The dendritic lesions had healed, stromal edema had decreased, the AC inflammation had reduced to trace amounts, and the IOP had dropped to 18 mm Hg with the topical treatment. Oral antiviral was discontinued after 10 days, but the topical steroids and IOP lowering agents were tapered off over the following weeks. At 1 month follow-up, patient's visual acuity was 6.9 in the affected eye. Complete resolution of inflammation and normal IOP, the patient was prescribed low-dose oral valacyclovir 500 mg once daily for long-term prophylaxis to prevent future recurrences. So herpes simplex keratitis is a leading cause of corneal blindness in developed countries. It can present in various forms: keratitis to stromal disease with or without uveitis. Recurrent HSV keratitis with anterior uveitis, and as seen in this case, poses a significant risk for corneal scarring, stromal inflammation, and secondary glaucoma. So the management of HSV keratouveitis is complex due to the need to balance antiviral therapy with the cautious use of corticosteroids to control inflammation without exacerbating the viral replication. So this case underscores the importance of early and aggressive management to prevent complications. Antiviral therapy is the cornerstone of treatment, while corticosteroids necessary to control the uveitis. Long-term antiviral prophylaxis is often recommended in recurrent cases, as it is notorious for recurrences that can lead to progressive damage and vision loss. So conclusion, recurrent herpes simplex keratitis with uveitis highlights the diagnostic challenges and therapeutic consideration in managing a viral keratouveitis. Prompt initiation of antiviral and anti-inflammatory treatment along with careful monitoring of IOP led to a successful resolution of the infection and inflammation. Long-term prophylaxis is essential to prevent future recurrences and preserve the patient's vision.
Very nice presentation, Ashna. One thing I want to ask, why did you use the atropine? You used cyclopentolate, and for how long did you use cyclopentolate?
Sir, for 2 weeks. When the patient came at 2 weeks, so the pain and the ciliary spasm, the pain due to ciliary spasm had reduced, so we had stopped it at 2 weeks.
After 2 weeks, did you look for the flare and cells if they were present? Should you have not continued that the cycloplegics?
Yes, sir, but sir, the reaction was minimal. So yes, we should have
Minimal. Look, if the patient is having inflammation, why didn't you use the cycloplegic till the eye is absolutely quiet? There are no flare and cells in the eye.
Yes.
And secondly, how long did you use your topical steroids? You used prednisolone. Earlier, with the caution, you could have used earlier the weaker steroids, because earlier when the epithelium is in a healing stage, the steroids delay the healing of epithelium. So it may lead to the basically other secondary infections and more, and delays all the healing process.
Sir, after 5 days of topical antiviral therapy, we started the patient on steroid. Okay. And after 2 weeks, we started tapering both the steroid and the other drug.
What was the frequency of tapering? Whether it was 5 days, 7 days, 10 days, the top tapering?
Sir, it was started at 4 times. So after 2 weeks, we tapered it at 5 days each.
5 days. You tapered it within a month, basically.
Yes.
You can say.
Yes, sir.
After 5 days, you can say it stopped in 1. I usually prefer to start with the 6 times day and weekly tapering of the dose of the steroid.
Yes, sir.
But there are different, it depends upon the how much is the amount of inflammation is there,
Yes, sir.
and how fast it recovers basically. So it was very nice presentation.
Thank you, sir. Thank you so much.
Any other presenter is there? Yeah, what's your name? What's your topic? At which number it is? Yeah, twist of fate, perspective insights into tectonic keratoplasty. Lihalin Chaudhary, please, do start.
Good afternoon, everyone. Today, I'm going to present about a study that is about tectonic keratoplasty, twists of fate. So, corneal perforation is itself an ocular emergency requiring prompt detection and intervention. It can be like infectious causes, non-infectious causes. Infectious can be bacterial, viral, fungal, acanthamoebal, or mixed. Non-infectious can be traumatic, lag ophthalmos related, keratoconus, Sjogren, idiopathic. So, what is tectonic keratoplasty? So, tectonic keratoplasty's primary goal is the tectonic closure of the perforated area to restore the integrity of the eye. That is the main aim. Subsequently, visual acuity can be addressed by further surgeries. Management of the corneal perforation depends on the size, location, cause, infiltration, and state of the internal tissues of the globe. Like small perforation can be managed by bandage contact lens, cyanoacrylate glue, amniotic membrane graft, conjunctival flap, or patch graft. Larger perforations need tectonic keratoplasty, and if globe is not salvageable, we have to do evisceration or enucleation. So we did a study that is a prospective study from January 2022 to July 2023 in Bhimsa Bulla. So it was a convenient type of sampling, included 28 samples. All patients with corneal perforation and melting with PL positive and accurate PRO included, and perforation less than 2 mm in mutilated eyeball, and inaccurate PRO excluded. So this was a study. Preoperatively, all patients are evaluated properly with based on the many variables like demographic, clinical, microbiological, histopathology, and treatment variables. So tectonic keratoplasty was performed. We performed the penetrating keratoplasty for all patients with proper consent. Post-operatively, patients were called for follow-up in regular intervals, and visual acuity was assessed for all. This was the observation based on my study. There were 28 patients. So as a result, I will highlight the main results for this study. So the main etiology was the bacteria, which was maximum percentage was for bacterial etiology, and improvement in VA was like 89% of the patient improved VA after the surgery, and 26 patients surgery was successful, and 2 only needed regrafting. So as a conclusion, tectonic keratoplasty is not just a surgery, it can change the fate of the patient who once lost the hope for they lost their eyes. It is like a miracle for the patient. So that is my study. Thank you.
Thank you. It was a nice presentation. Your institute has a HOTA that you're doing. Institute is doing tectonic keratoplasties.
Yes.
Right. It was very nice presentation, and savior basically
you,
when
sir.
the patient has lost all the hopes for this vision, and
Yes,
acts as a savior. Thank you.
Yes, sir. Thank you, sir.
Any other presenters? All are gone. बाकी आए नहीं। बहुत है। अगर आ जाए तो मुझे बता दो। आप कौन सी इंस्टीट्यूट से हैं ना? अच्छा सारे एएमयू वाले। आप ही एएमयू से? बुर्ला। तुम्हारे पैर में मिले थे मुझे। एएमयू में आपका कौन सा ईयर चल रहा? फर्स्ट ईयर। ग्रेजुएशन कहाँ से किया आपने? एएमयू से। वो रजत का लड़का वहीं पर है ना? He's doing MBBS. He just finished his MBBS. Paid for the NEET के लिए right now. डॉक्टर रजत माथुर है अम्बाला से. उनका बेटा है. नाम तो मुझे याद नहीं उसका. It was nice presentation by you. और actually it's a platform for basically आपके लिए सबके सीखने के लिए और ग्रेजुअली क्या होता है इवोल्यूशन होती है इसकी इनिशियली डर लगता है सबको ना जब हम फर्स्ट टाइम स्टेज पे चढ़े थे तो ऐसे बैक कर बट यू आर बेटर प्रेजेंटर देन मी फॉर द फर्स्ट टाइम इट वाज योर फर्स्ट प्रेजेंटेशन